First one in. get started on here. Okay, we can go ahead and start now. We're going to continue the urinary system and finish that up today. And if we have time, we're going to start fluid and electrolytes. Anybody have any questions on anything so far? Okay. 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 As long as she's still alive, that's okay.
Yeah, she's fine.
Okay, that's good. Okay, so barring any questions, then I'm going to go ahead and open up the urinary section where we stopped the last time. And the last thing we had taught, we were just getting into how we get materials back, because we know we filter a tremendous amount of blood. 180 liters of blood filtered in a 24-hour period. We're going to circulate that through our entire supply goes through the kidneys every 45 minutes. I mean, we would very easily dry up if none of that was recovered. I mean, we would just shrivel up because all that fluid would be leaving. So we don't want to lose it. We want to get 99% of that back. Because we only pee away about 1.5 liters a day. In a 24-hour period, about 1.5 liters we lose through urine. Now we're busy replacing that all the time by drinking and by the food we eat too. So we got to get everything back. And how do we do that? Well, the first place we recover filtrate, because that's what it's called, filtrate. Once it goes through the glomerulus, it's now filtrate. First place we start that is in the proximal tubule. We absorb water, we absorb salt, we absorb glucose, we absorb ions, we absorb vitamins at the proximal tubule. Remember, the proximal tubule is only 1 cell layer thick. And what we can't, and then from there, material that's in the proximal tubule moves into the peritubular capillaries, which are also 1 cell layer thick. And while the diagrams look like they're sort of wrapped around the kidney tubules, let's say it that way, they're really butted up right next to them. So there's probably like an extremely tiny space between the tubule wall and the capillary. But we will move into that little tiny space, even though they're butted up next to, there's a little bit of interstitial space there. They'll move into that space and then move into the peritubular capillary, usually through osmosis. Now, some stuff has to get pumped out of the tubule. We use the sodium potassium pump for that, but other stuff just diffuses naturally across there from a high to low concentration. So now, we're going to get back all of our organic nutrients, meaning glucose, for example. The movement of water and the movement of salts are controlled osmotically and through the use of various hormones like antidiuretic hormone, but that's not going to happen until we get down to the collecting duct. So up until the collecting duct, everything is pretty much driven by osmosis or the sodium potassium pump. So we may use the sodium potassium pump to get materials not into the tubule cell, but to get it out of the tubule cell. So these are the tubules. We have the proximal convoluted tubule, we've got the loop of Henle, and we have the distal convoluted tubule. Now the proximal tubule is going to get 65% of all the filtering. It's going to recover all that. Mostly water, some sodium, some bicarbonate, glucose, amino acids, vitamins, anything like that, any nutrients we would need. We're going to recover that. We're going to recover that. The little light blue arrow going up means we're going to recover that into the peritubular capillary. The little green arrow, where we see hydrogen ions and ammonia and certain drugs, we may be secreting those into the tubules at that point. that means that they were too big for whatever reason, or they were unable to get across the glomerulus, or for whatever reason, hydrogen ions didn't make it across there. But ammonia, chemicals from drugs, chemicals from food are going to be, the green stuff is secretion moving into the tubule. Things that were too big to get filtered at the glomerulus. So the proximal tubule is going to get back a lot of water and a lot of salt, phosphorus, and glucose and amino acids, but it's also going to pick up hydrogen ions. It's going to pick up ammonia from the waste products of breaking down protein. And most of the drugs that we, recreational pharmaceuticals, regular pharmaceuticals, drugs that, food additives, as well as the chemicals like the stuff that makes onions smell funny and makes our pee smell funny, and the same thing with asparagus. Now the loop of Henle, the long loop in there that drops down into the medulla, it has pretty much, you're going to get a lot of water out. On the descending side of the loop of Henle, you're going to have water come out. On the ascending side, you're going to have salt come out, but you're also going to pick up urea. Now, urea can go across the membrane very, very easily. Urea has no trouble crossing the membrane. Urea has no trouble going across the glomerulus, so we can get rid of it there too. It's a tiny molecule, but we're going to pick up more urea here. Again, it's being secreted into the tubule. It's still filtrated. It's not urine yet. We move up into the ascending portion of the loop of Henle, and we're going to, now on that side, we're going to get rid of sodium and potassium and chlorine out of the filtrate. We're going to get sodium out. We're going to take out sodium. We're going to take out potassium. We're going to take out chlorine. Chlorine doesn't get to do anything. It just watches. It's not an important ion for us. So descending side, we recover water. Ascending side of the loop, we recover sodium, potassium, and chlorine. What we get into the distal tubule is a pretty clean filtrate. Now, what happens in the distal tubule? This is where aldosterone works. Aldosterone allows us to recover more sodium here. Remember, aldosterone comes out of the adrenal cortex. It's a mineralocorticoid, renin, angiotensin, aldosterone. We've talked about that before. Aldosterone acts on the distal tubule. This is where we recover sodium, which means we have to recover water to go with the sodium. Chlorine follows the sodium just because it does, because sodium chloride, But the other thing that happens here in the distal tubule is calcium recovery. When the parathyroid hormone acts on when the parathyroid hormone is released in response to low blood calcium levels, and we're busy digesting, we're digesting away bone. Well, that's one of the three things that parathyroid hormone does. The other one is allows us to recover more calcium in the small intestine. We need vitamin D for that. And the third thing is to recover more calcium in the kidneys. And this is where we do it. Parathyroid hormone acts on the distal tubule. This isn't nearly as exciting as what's happening in the proximal tubule, because the proximal tubule is doing everything. This only gets to work if we got aldosterone and we got parathyroid hormone. And if we recover sodium at the distal tubule, we got to get rid of potassium. Aldosterone is saying, okay, we recover sodium, we're going to get rid of potassium, because we got to stay balanced. Our ionic concentration has to stay balanced. Sodium is recovered, potassium has to go. On the other hand, if we're retaining potassium for whatever reason, then the sodium has to go. So, but anyway, this is what's happening in the distal tubule. If we stopped at the end of the distal tubule, we would have a perfectly fine dilute urine. It would be pale, it would be clear. It would be almost, it would be a very dilute urine, but that would be just fine. But we have one more place to control the filtrate. The recovery of additional water happens in the convoluted, in the collecting duct, which is over here. This is the collecting duct, and antidiuretic hormone, if it's released, will recover water. The collecting duct becomes permeable to water if antidiuretic hormone is present. So we recover that water. If we recover the water, we're going to recover more sodium. And we can also recover urea here too. So, and we have one other shot here of getting rid of more potassium. Remember, aldosterone is still going to act. Aldosterone comes into play again. Aldosterone is going to tell us to recover sodium. And when we recover sodium, we drag the water along. I mean, after all, the antidiuretic hormone is busy recovering water. Sodium is going to follow that osmotically. But we're going to recover if we have aldosterone and we're pulling sodium out up in the distal tubule, we're going to pull it out on the collecting duct too. But let's just say we don't have any aldosterone. We're just going to, if we don't have aldosterone, we're just going to recover water here because the collecting duct is permeable to water thanks to antidiuretic hormone. We recover water, sodium follows the water. Salt always follows water, and water always follows salt. And so what happens is that with the presence of antidiuretic hormone, we go from a very dilute urine to a very concentrated urine down at the bottom of the collecting duct. Now we have urine. It stops being filtrate. Somewhere in the collecting duct, it stops being filtrate. We start calling it urine. And depending on whether we have antidiuretic hormone or not, if we have antidiuretic hormone, then we're going to produce a concentrated urine. If we don't have it, we're going to produce a dilute urine. Anything that inhibits the action of ADH is going to produce a dilute urine. You know, if you drink alcohol and you have several glasses of some beverage with alcohol in it, you're going to discover that you have to pee more frequently because alcohol inhibits antidiuretic hormone. So you pee more frequently, and the more often you pee, the urine's going to be very, very dilute. You are not recovering all your water like you should, and you ultimately become dehydrated. If you take in a lot of alcohol, you're going to pee a lot, you're going to be dehydrated. That's just the way our bodies work. So, or so they tell me. So anyway, now, so this is what's happening in the three places where this is how we recover 99% of all the water. We're out of all the blood going through here. The total amount that's going to pass through in a 24-hour period is 180 liters. Obviously, we don't have 180 liters. We have about 8 liters. We pass through there. All we generate is about 1.5 liters of urine. So instead of peeing away 180 liters of filtrate, we pee away about 1.5 liters. But see, we recover that every day by drinking more water. We drink water and eat food, and it's replaced, whether you're drinking a bottle of water or coffee or water. Well, everybody's drinking water except me. Y'all know something like that?
I drink my coffee on the way here.
Ah, okay, good. Okay, well, there you go. And there you go. Okay, so it's okay then. Now, it turns out that sodium is really important to us because sodium controls most of the reabsorption. There are more sodium ions than anything else in our filtrate, and that makes sense because the #1 ion in our plasma and in our interstitial fluid and in our filtrate is sodium. You know, it's the #1 ion outside of the cells in our bodies. and we have more sodium in the filtrate than anywhere else. So when the filtrate goes into the proximal tubule, the sodium concentration is higher in the filtrate than in the cells that surround it. So obviously sodium is going to move through diffusion right into those cells. So there's your tube, your proximal tubule. It's a hollow tube. It's made up of nothing but simple cuboidal cells. The sodium, the concentration of the filtrate is very salty, and the salt concentration is higher in the filtrate than inside the cells. We know, think about that for a second. We know that because if let's go back to membrane potential for a second. I know everybody loves membrane potential. What's the on the outside of a cell? Sodium. What's on the inside of a cell? Potassium. That gives the cells their positive and negative charge. High sodium's outside, give us a positive charge. Low potassium on the inside gives us a negative charge. So we automatically have more sodium outside of the cells to begin with. Now we've got this tube that's formed by these cells, and we have this salty filtrate in the tube. So the sodium concentration is even higher now than it was before. So sodium is going to move passively into those simple cuboidal cells, but now they're stuck in there. So how does the cell get rid of them? It pumps it out. Because if you have high sodium outside the cell in the tubule and it moves in from the tubule, how's it going to get out to the other side? Because it's high on the outside of the cell too. You have to pump it out. You have to use your sodium potassium pump. And if I get my picture here, there we go. It's a pretty simple illustration here. There's our tubule up. I told you it was simple. There's our tubule up at the top. It's made up of simple cuboidal cells forming a hollow tube. The filtrate is salty. That's that yellow stuff out over here. This is the filtrate. We're in the middle of the tube right here. So the sodium here is high. Cells normally have low sodium. They have high potassium, but low sodium. Every cell is like that. So the sodium will diffuse in from, this out here is the yellow stuff is the filtrate. Sodium is going to move in here because it's higher than what's inside the cell. So it slides in here passively. But when you get out to the interstitial fluid on the other side of the cell, because now, remember, this is the inside of the tube. This is the outside of the tube over here where it's pink. I don't know if it's pink or not, but we'll just say it's pink. That's the interstitial fluid that normally surrounds every cell. Sodium is high there too, because sodium is always high in interstitial fluid. You get sodium to come into the cell, it's not going to go out passively because it's high here, it's high here. It's high on the outside of the cell. When it's high on the lumen side of the cell, it's high on the outside of the cell. So we have to pump it out. So that's how we get rid of our sodium. It comes in passively, then we pump it out into the interstitial space, which is right between the tubule wall and the peritubular capillary. And then sodium can move into the capillary. So, but now we see what happens to sodium. Sodium can drag along glucose, because sodium will often, when sodium diffuses into a cell, will often drag along glucose with it. And sorry, I already said that. Let's go back here to another picture now. There we go. This is, let's look at the other things that come along here. Now, this is our peritubular capillary over here in purple. And this is the interstitial space here. Now the capillary is butted right up against the tubule. This is one side of the tubule right here. Remember, because it's a whole circle. It's like a hose. Sodium comes in passively. It drags glucose with it. High levels of sodium get pumped out of the cell into the interstitial space, and the glucose is going to diffuse back into the interstitial fluid and into the capillary. So by getting the glucose to piggyback with the sodium, we get the glucose in the cell. We have high glucose inside the cell, and it will move out into the interstitial space and then move into the capillary, and we recover all of our glucose. We also see that our amino acids and our ions and vitamins are going to move across passively the same way. Anything fat soluble is going to move across passively. It's all going to come through, either through the membrane, or in some cases, we're going to have channels right here. So again, the big thing that sodium does is creates through diffusion there, it creates the high concentration of sodium on the inside of the cell, which then forces the cell to use active transport to pump the sodium out. But that, by doing so, it creates the ability of moving the glucose through secondary active transport into the cell and then out again. And we get the glucose back into the capillary where it belongs. So that's how we recover everything. It's all driven by sodium, at least in the proximal tubule. Things that don't get reabsorbed are things that are too big, or they're not fat soluble, or there's no carrier protein for them. So urea doesn't get reabsorbed. Urea is tiny. It will filter through the glomerulus. There's probably, I think there's at least a practice test question about urea for test 4. Can urea pass through the glomerulus easily? Or urea isn't filtered because it's too big? Well, and the answer, no, urea goes through the glomerulus very easily because it's a tiny molecule. We push urea through the glomerulus all the time into the filtrate, but we don't bring it back in. We don't recover it. Creatine, urea, and uric acid, these are all waste products. These are all nitrogenous based off of ammonia, waste that we want to get rid of. This is the stuff that if we don't get rid of it, that accumulates and kills your patient when their kidneys fail. Those kidneys, yeah.
Didn't you said that they're too small to pass through, or they're so small they pass through?
They pass through the glomerulus into the filtrate, but then they don't get reabsorbed. They're in the filtrate. Once we get rid of them, we don't want them back. So, because they don't have a way, the only way they got through the glomerulus is because the glomerulus has holes. So they pass through the holes, they go into the filtrate, but the proximal tubules won't let them back in. So they have no way to get across the cell membrane. Because remember, the tubule is made up of cells, and you have 2 membranes to cross. You have to cross the membrane. Let me go back here. There we go. You have to cross the membrane on the inside of the tube, and you got to cross the membrane on the outside of the tube. And urea can't get across either one. So we don't reabsorb these nitrogenous wastes because we don't want them. Because we've got to get rid of them. We don't want them to accumulate. Now, we do have to get rid of other stuff that's too big to go through the fenestrations, through the glomerulus. We are going to take stuff out of the capillaries, large molecules of waste products like catecholamines, like things that make, when you eat asparagus, the results of eating asparagus. So, and I've been experiencing a lot of that lately because Walmart's had asparagus on sale. So, and I love asparagus. So, you don't need to do a physiology lesson while you're emptying your bladder, but it happens. Okay, the tubular secretion, the molecules, they passed through the glomerulus, but they didn't go through the openings. They were too big. So they're in the peritubular capillaries, but now they can be secreted from the peritubular capillaries into the tubule. So we can get rid of things that we didn't get rid of enough of before. We get rid of more urea, we get rid of uric acid. We can get rid of potassium. Now, potassium removal usually takes place in the distal tubule, but it's still one of the part of the tubule. And so we can remove the stuff that we want to get rid of, like, chemical waste products, food additives, things that we don't need, things that are present in things we eat and drink. We're trying, naturally occurring chemicals like the stuff in onions and asparagus again. Anything along those lines that are just too big. When we take a prescription drug, a medication for something, like if you take amoxicillin or any of the penicillin type drugs, you will eventually detect the odor of the penicillin type drug in your urine. In fact, early on when penicillin was first discovered, it was often recovered from a patient's urine and then purified so they could use it again because they didn't have enough of it. So they were able to recover it and get, it at least concentrate it and use it again because it was so valuable at that point. So they didn't have enough of it. We can control our blood pH by reabsorption. Here's where we're going to start excreting hydrogen ions or excreting bicarbonate ions, because that's how we regulate, our pH. So we can, because the kidneys have a big role in maintaining our acid and our base levels. They're a little slower than the lungs are, but they still have a big role to play here. So we secrete these things. Like I said, aldosterone. If aldosterone is present and we're recovering sodium, then we got to get rid of potassium. We get rid of the potassium at the distal tubule by secretion. So, now, there's a term here called osmolality. And, I'll trip over it. I'll say osmolarity, and we'll probably use it interchangeably, even if it is incorrectly. But what we're talking about is how many solute particles do you have in 1 liter of water? Doesn't matter what the solute particles are. What it's looking at is the number of solute particles determines how well the solution can trigger osmosis across a cell membrane. Because remember the definition of osmosis: movement of water from high water to low water. High water means low solute, and low water means high solute. If you have a 10% salt solution in a cell membrane and a 20% salt solution on the other side of the membrane, if you have a 10% salt solution, it's 90% water. If you have a 20% salt solution, it's 80% water. 90% is greater than 80%, so water will always move from the higher water side to the lower water side. So the presence of the solute concentration determines which way water is going to go in that solution when you have a membrane in between from higher water to lower water. So we measure the osmolality of our body's solutions, our interstitial fluid, our plasma, our filtrate, the cerebrospinal fluid. All the fluids that we have are measured in milliosmoles. Now the magic number is 300 milliosmoles, because that means that if we have 300 milliosmoles, that means the solute particles on one side of a cell membrane are the same as the other side. That's what we like to see. We have interstitial fluid and intracellular fluid, I said that correct together. The fluid inside the cell and the fluid outside the cell are both about 300 milliosmoles. That way we don't have any there really isn't a lot of movement of water from the interstitial fluid into the cells or from the cells into the interstitial fluid. Water levels stay pretty constant in here. So the plasma is 300 milliosmoles, the interstitial fluid is 300 milliosmoles, the cells, the inside of the cells are 300 milliosmoles. And the way we keep ourselves in this balance, if you will, oh, I get to say homeostasis, I haven't said that for several months, so is something we call the countercurrent mechanism. Now, the countercurrent mechanism is probably the most confusing thing to try and understand in the kidneys. So when you're done with this class, you'll be able to say, well, how do the kidneys keep our salt levels the same? And you can say through the countercurrent mechanism. And that's all you have to remember. What happens here is our filtrate's formed, and it's about 300 milliosmoles after it leaves the glomerulus, and it goes through the proximal tubule, and it starts heading down the loop of Henle. As it goes down the loop of Henle, we start pulling out more and more water. Well, the salt concentration in our bodies is pretty much set. Our salt levels don't vary a whole lot. However, if you have a set solution with a certain amount of salt present, if you start pulling more and more water out, what's going to happen to that solution? It's going to get saltier. I mean, my old analogy of I have a beaker with a liter of water in it and 100 grams of salt. That's a 10% salt solution. If I let that thing set out, I want to do that one of these days. I keep saying that, but I haven't done it yet. If I let that thing set out and evaporate to where we have 500 mils of water in the beaker, I started with 100 grams of salt and a liter of water. I'm now at 500 mils of water. Did I lose any of the salt? No, I still have 100 grams of salt. That solution is now 20% salt simply by pulling the water out. If I let another 250 or whatever mils of water come out, I'd be 40% salty. So simply by losing the water. And that's how our bodies work. Our salt levels don't really change a whole lot, but the water does. And so we can be saltier or less salty by how much water we have in our plasma, in our interstitial fluid, in our filtrate, whatever. Now, as the filtrate moves down the loop of Henle, we're pulling out more and more water. And that we're leaving the salt behind, and we can go all the way from normal at 300 down to 1200 milliosmoles. It is very, very salty at the bottom of the loop of Henle. So we've pulled a lot of water out of that filtrate. Now the filtrate that's very salty now starts going up the other side of the loop of Henle on the ascending side. Now we've just pulled a whole bunch of water out into the tissues, interstitial spaces around the loop of Henle. There's a lot more water on the outside of the loops than there is on the inside. Now the sodium, so we have a lot of water here on the outside, but now on the ascending side of the loop, the ascending loop is impermeable to water. The descending side lets all this water come out. We pull water out. That's great. And the filtrate now is very, very salty. So it starts going up the ascending side. Now, the reason we make the ascending side impermeable to water, because if we generate this real salty fluid here, that water's going to want to come back in. So we make it so the water can't come back in, but the salt can leave. So now salt will leave the salty filtrate and move back into the tissues or into the peritubular capillary. So let me show you if I got a picture here. I just said that. There we go. This is what it looks like. And this is a very confused, you know, there is no good explanation for the countercurrent mechanism in the kidney, but I'll try. On the descending side, all that water is coming out. The descending side is permeable to water. And we pull out more and more water. Water moves osmotically from the filtrate into the interstitial spaces. We get down to the bottom of the loop of Henle, and the concentration is 1200 milliosmoles. The ascending side is impermeable to water. Water can't leave, but it is permeable to salt. So salt diffuses out from high salt, high sodium to get out into the tissues of low sodium. By doing so, it keeps the tissues very salty. The salt concentration is very high out in the interstitial spaces. That's what pulls the water out initially. Bottom line is we pull so much salt out that our filtrate, when we get to the top of the distal tubule, is 100 milliosmoles. And that could be our urine if we wanted it to be. That is the ultra dilute urine that gets produced. Yeah, 100 milliosmoles. That means it's not the solute concentration is pretty low in there. But we have one more chance to recover water in the collecting duct. We pull more water out through the collecting before it leaves the collecting duct, and our salt concentration goes all the way back to 1200. So what do you need to remember from all this? 300 milliosmoles is the normal osmolarity or osmotic concentration of plasma. At the bottom of the loop of Henle, we've sucked so much water out that it's 1200 milliosmoles, super concentrated. At the top of the collecting duct, where we've pulled so much salt out, we're only 100 milliosmoles. And we can, if we pull more water, if we don't do anything else, we have a dilute urine. This is what happens without antidiuretic hormone. If you inhibit antidiuretic hormone, your urine's going to be 100 milliosmoles. It's going to be transparent. It's going to be, have absolutely no color to it at all, and you'll be peeing a lot. For whatever reason, it's inhibiting the release of ADH. On the other hand, if ADH is present, then you're going to suck water out and you're going to produce a concentrated urine of about 1200 milliosmoles. So when you pee and it's bright yellow, that's about 1200 milliosmoles. It means you've recovered. It's telling you recovered a lot of water from that urine. So, because if the urine is pale, clear, pale, transparent, it means it's very dilute. If it's constant, if it's bright yellow, a healthy yellow, it means it's concentrated. So, okay. So where does this countercurrent exchange take place? It takes place deep in the medulla. The medulla has a higher osmotic concentration than the cortex. The cortex runs around 300 milliosmoles. The medulla, deep in the medulla, is around 1200. So the countercurrent mechanism, it sounds really complicated in how it works, but it does maintain the concentration gradient we want to have in our filtrate. For what it's worth, right here. Here we have our descending loop. Here, water goes out. Water goes out. On the ascending side, water can't get out, but sodium can leave. And I just said this already. I'll say it again. If we didn't do anything else to the filtrate after going through the loop of Henle, we would have an ultra dilute urine. We can have urine that is osmotically down to 50 osmoles. So you have a patient that's been ingesting alcohol all evening and they're peeing constantly and their urine is transparent. There's nothing in it, essentially. Its salt concentration is probably 50 osmoles. Normally, when we get to the end of the distal tubule, we're about 100 milliosmoles. If your patient is staying hydrated, drinking lots of water, if you are drinking, in fact, if you're overhydrating, you'll have the same effect. Excessive levels of water will also give you that dilute urine. Now, I just said all that. Okay. Now, antidiuretic hormone is much more important than we ever knew. Antidiuretic hormone, which we correctly call vasopressin, in addition to being recovering water, is also a very powerful vasoconstrictor for us. So we raise our antidiuretic hormone actually raises our blood pressure because we're recovering water. Where's the water go? It goes back into our blood. Blood volume goes up, blood pressure goes up. But it's also a vasoconstrictor. So when we squeeze our vessels, our pressure goes up too. So now, how often do we release antidiuretic hormone? Well, if our urine is too dilute, we may not release antidiuretic hormone. Now think about this. You've just lost a bet and you're going to drink 6 liters of water in 5 minutes. Yeah. So probably, but it's either drink 6 liters of water or paint your face green. Yeah, I thought you would. So, okay. So you're drinking 6 liters of water. Where's that water going to go? It's going to go in your plasma, right? Everything we eat and drink goes into our blood. So you increase your water level. You dilute your plasma concentration of sodium tremendously. That's going to inhibit the release of antidiuretic hormone. Remember, antidiuretic hormone keeps you from peeing. So you drink 6 liters of water, you've lowered your osmotic concentration. What are you going to be doing? Peeing like crazy. Yeah, to get rid of that, because antidiuretic hormone only prevents us from peeing, from urinating, so that we don't lose too much water. But in the case of overhydration, we're going to pee a lot. There's actually a term for it: water intoxication. Excessive intake of water is just as bad as no intake.
Can it make you throw up too?
Oh yeah, easily. You see these people at the end of a marathon chugging down 4 or 5 bottles of water, and then they have to turn and run off this, out of the camera because they got to hurl it all back out. But our antidiuretic hormone is designed to maintain the correct osmotic concentration. That's why we recover water. That's why we don't pee very much if we're trying to recover water. If we release ADH, then we're not going to pee. Antidiuresis, antidiuretic. If we don't release it, then we're going to pee frequently. The whole idea is to maintain the level of, keep our osmotic concentration correct. So, and we do this at the collecting duct. That's where antidiuretic hormone works, is on the collecting duct. And we got, yes, good point. If you try to beat a urine drug screen by drinking huge amounts of water, the sample will be dilute, and you have to wait for the sample to become less dilute. Just saying. So
Is that because there's so much water that like your kidneys or somewhere can't, the toxins don't get in?
Well, the concentration is more dilute than it should be, you know, because the more water you take in, the more dilute your urine's going to be. And so if the drugs that are in the screen aren't going to be detected or going to be, well, still be detected, but they'll be skewed because there's so much water there. So you have to wait, you know. So it's just an approach to try and beat the drug screen. So, no, it doesn't work. You know, you might look. Oh, no, you've got a friend, right? You've heard friends talk, right?
Honestly, yes, but
I know. I'm just, you know.
Personally, no.
Yeah, I know. I'm just, you know, the classic response is always, well, I've got this friend, you know, that, and fill in the blank, you know.
No, but I actually have heard like people like drink a bunch of electrolyte or something else. It like makes you to where you can have a I don't know.
I've heard of people taking sure gelatin.
Yeah.
And drinking that and claiming that it like gels their kidneys over so the toxins can't be released into their urine.
Like they add it to Pedialyte
And
Okay.
sugar.
and then drink it. And
Okay.
Then drink a whole bunch of water after that. It's like, why would you?
That's where they has to drink it that way.
Yeah, that's
And their kidneys is yellow.
yeah.
You'd be sitting in the clinic.
You'll be sitting in the clinic all day. It doesn't work. Yes. You know,
That's fine.
it is because, you know, if any of this stuff worked, we'd never hear about it.
Right.
Think about it. If it worked, we'd never know, you know, so. Okay.
That's fine.
Now, antidiuretic hormone is also our friend on a hot day. You're outside working it in the heat and you're sweating profusely, which is what you do, or rather you perspire. And if you don't stay hydrated, you're not going to have to urinate. Your kidneys are busy filtering, you know, your plasma, you know, constantly. But because you're not replacing the water you're losing through perspiration and from breathing out, the kidneys will be stimulating the release of a lot of antidiuretic hormone so that you don't have to pee. And so at the end of the day, when you realize, oh, you know, I forgot to get some drink water. I can see how that could happen. You get busy, you forget, you know. So you have forgotten to drink anything. At the end of the day, when you finally get around to urinating, the urine is very concentrated because we've been retaining water as best we can. The kidneys have been protecting us from becoming dehydrated by concentrating the urine. And then when we pee, we get a nice bright yellow, funky smelling stream from here. It works. You know, the people that hike up in the park and they, you know, they get all the way up to the top of Mount LeConte, for example, and they haven't stopped to pee anywhere along the way. That's telling them, if they were paying attention to it, that they are dehydrated. You know, the saying essentially something to the effect, if you're not peeing, you're not drinking.
So it's not preventing you from being dehydrated.
It's slowing it down. You know, slowing it down. It's retaining as much water as you can. So, okay. And vasopressin, antidiuretic hormone, you're either going to, if it's present, you're on the right-hand side. On the left-hand side, if it's present, you're going to recover a lot of water. You're going to generally produce a concentrated urine of about 1,200 milliosmoles. If it's absent, then the urine that's coming out is going to be the same concentration as the filtrate when it left the distal tubule, which is about 100 milliosmoles. So when you produce a very clear, transparent, clear, pale, transparent, you know, pale yellow, if anything, urine. So because the antidiuretic hormone will work to recover as much water as possible as long as it's not inhibited. And it gets inhibited by alcohol. It gets inhibited by high levels of water. So, again, if some is good, more is not necessarily better.
So salt goes on our food black and comes out in urine yellow.
That's all the other chemicals in there. The urochrome is the pigment that gets released when we process it, and that's coming from the ammonia and the nitrogen waste. So term here, diuretics. When we've been talking about anti-diuretic hormones, diuretic is a drug that triggers urination. We want to, sometimes we need to use a diuretic. A patient suffering from edema of some sort may need to take a diuretic. So and they work by blocking recovery of sodium. A diuretic is generally not absorbed, or it blocks the release of ADH. So alcohol and caffeine are diuretics. Alcohol is very simple. It blocks the posterior pituitary from releasing antidiuretic hormone. Very simple process. Drink alcohol, you'll have to pee. So caffeine works the other way. Caffeine will inhibit the absorption, the recovery of sodium. So if you don't recover the sodium, the water and the sodium stays in the filtrate, water will stay there too. In fact, water may be drawn into the filtrate. So you drink a lot of coffee, consequences drinking a lot of coffee, you got to pee. So we're not getting our sodium back out of the filtrate, and that ends up pulling water. If the sodium concentration in the filtrate goes up, then water is going to leave the peritubular capillaries, move across the interstitial space into the tubule cells and into the filtrate. Because if you have a lot of sodium in the filtrate, you're going to have high solute. And what does osmosis do? Water goes from high water, which is low solute, to low water, which is high solute. If the sodium concentration is higher in the filtrate than in the interstitial fluid, then water is going to leave the capillaries, go through the interstitial fluid, through the tubule cells, into the filtrate to try and dilute that urine, dilute that sodium. And so you're going to pull more water out. The same thing applies with glucose. The reason your diabetic has to pee during as one of the cardinal signs of diabetes mellitus is frequent urination. Well, your patient with diabetes will have high levels of glucose in their filtrate, because that glucose isn't being absorbed into the cells. Remember what diabetes mellitus, the root cause of this is usually a lack of carrier proteins to allow the glucose to come into the cell. Well, because they're not producing enough insulin. We all know that. The end result is we have lots of glucose inside the filtrate. Well, that glucose is acting like a solute particle, because it is a solute particle. It doesn't matter that it's sugar. It acts as a solute particle, creating a high solute concentration in the filtrate. So what happens? Water moves from the peritubular capillaries through the cells into the filtrate to try, higher water in the plasma versus lower water in the filtrate because of all the sugar there. Water moves into the proximal tubule, try and reach equilibrium with the solute concentration caused by the glucose. High levels of glucose cause a lot of water to leave the peritubular capillaries. And what happens is you got to pee. That's why you have to pee a lot with diabetes, because the glucose in the filtrate's pulling the water osmotically from the peritubular capillary. So now diuretics are actually a good thing, when used correctly. You know, prescription pharmaceuticals, are Lasix and diuryl. They are going to cause your patients to lose water. They're retaining water for some reason, usually through perhaps congestive heart failure. Maybe they've got systemic edema. Maybe they've got pulmonary edema, and they take these medications so they can pee away a lot of water quickly, or maybe they're a racehorse and they want to lose weight. Lasix is what they use with horses too, by the way. So anyway, but both of those work by blocking the symports that allow sodium to move into the tubule cells. So if the sodium doesn't go into the tubule cells, it stays in the filtrate, and that causes more water to be pulled out of the peritubular capillaries, which is drawing from the tissues where it's being retained as edema. And so they pee a lot. A lot of very sketchy weight loss drugs work the same way. They're really, they're all, most of them are based on caffeine. Take these, you'll lose 300 pounds in a week, type of thing, and all they do is make you pee. And a person who takes a diuretic drug that doesn't need a diuretic drug, it's a dangerous alternative, because the thing is, these weight loss drugs that work by peeing, it's a temporary thing. The amount of time that there's a weight loss is measured in hours, maybe days, but definitely only in hours. And of course, you're messing with the whole ionic composition of your body too. So there is a real risk factor here. I mean, you could get the same result if you drank 12 cups of coffee, and you probably enjoy that a whole lot more than taking these weight loss pills. So
Would Lasix be used for both types of heart failure, or just?
well, I've heard it's used. It can be used for systemic, where you have swelling in the arms and legs. Yeah. So I don't know if it's used for pulmonary edema or not. It might be, but I know it's been used for systemic edema. So, oh, and that's the end of the urinary system. Anybody have any questions on any of this? No,
Did you say we're gonna start fluids and electrolytes?
I'm going to try and start fluid and electrolytes. So let's go. Okay. Well, there's plenty of plugs. Okay, I'm going to bring up fluid and electrolytes here in a second. And fluid and electrolytes. And you should all see the slide that has one of the Williams sisters on the front of it. So, okay. Didn't it work?
I think we got it. I think we get it up.
Okay. Okay. Yeah, if you want, I can pry it open if you want.
Oh. You don't have to.
Here, you want to try it? I think you can look at the metal.
I couldn't get my fingernail under it. That's not all I needed to do. Was pull it up like that.
There it is. There you go. Okay. I found out the hardware.
You want this one?
I thought it was right
You want bone?
Do it. There we go. Yeah,
Sorry.
yeah. I tripped over that one day and almost took a header at the back row. So that's how I discovered how they opened. So the hard way. So, okay, we had some technical difficulties here in the classroom, but I think we're okay now. As okay as we can ever be.
Sorry.
No, it's fine. Go ahead, so, okay. That's fine. Okay, fluid and electrolytes and acid-base balances. If you like the urinary system, you're going to love this. That was sarcasm. So, okay. We generally have two compartments of fluid in our bodies. We have all the water that's in our cells, the intracellular fluid, and that's about 2/3 of all the water in our bodies found inside the cells. The extracellular fluid is everything else. It's the plasma and it's the interstitial fluid. Now, plasma becomes interstitial fluid. Interstitial fluid becomes lymphatic fluid, which becomes plasma again. And we do run off, we also run a section through our kidneys all the time too and generate filtrate. But we're just, that was plasma and it becomes plasma again. Interstitial fluid was plasma, becomes interstitial fluid collected by the lymph system and is returned back to the plasma. So these are, the two areas of extracellular fluid are either the fluid in the blood or the fluid around the cells. And if we're being picky, we can include the lymphatic fluid, the cerebrospinal fluid, all 6 ounces of it, the fluid inside the humors of our eyes, the anterior and posterior humors, the synovial fluid around our joints, the serous fluid covering the ends of our bones and covering between the visceral and parietal layers of the serous membranes, and anything our gut's releasing for us. But for our discussion, we're going to primarily focus on the interstitial fluid and the intracellular fluid, what's inside the cells and what's outside the cells. So how much are we talking about? Well, the total volume of water in our bodies is about 40 liters. 40 liters. About 25 liters are inside the cells. That's that intracellular fluid. We have 12 liters around the cells in the interstitial fluid, and we have 3 liters in our plasma. So altogether, 40 liters of fluid. Now, if we lose water, so now, and let me back up. The osmotic concentration of the water in the plasma is the same as in the interstitial fluid, which is the same as inside the cells. What the way how we regulate all this, the osmotic concentration, is not by gaining or losing salt, but by gaining or losing water. If we lose a lot of water from the extracellular side, from the plasma or the interstitial fluid, then our salt concentration goes up. Remember what I said about that magic beaker with 100 grams of salt inside of it? If we lose water from the plasma and lose water from the interstitial fluid, the amount of salt that's there stays, the total amount of salt stays constant, but the water level drops, so the salt concentration is going to rise. Take away water, leave the salt behind, the concentration goes up. You have a liter of water with 100 grams of salt, you evaporate off 500 mils, you still have 100 grams of salt, but now it's in a half a liter. It went from 10% to 20% just by losing the water. So if we lose water, from the interstitial fluid, the salt level goes up. The cells are going to respond by sending water out from the cells to the interstitial spaces, driven by osmosis, because all of a sudden your salt concentration is higher outside the cell than inside. Well, that means that you got high water inside the cell, and the water leaves the cell and goes to the outside. So when we get dehydrated, our cells are going to shrink because they're going to give up water. We don't like that. Our cells will shrink when we become dehydrated. Cells don't like to shrink. We're not like plant cells that shrink and expand all the time. Brain cells do not like to shrink at all. They don't like to give up their water, but they will if we're dehydrated, because they're going to try and reach equilibrium again with the outside of the cell. If we overhydrate, and the term is hypotonic hydration, if we overhydrate, if we drink too much water, the interstitial fluid, water in the interstitial fluid will rise. That will dilute the salt. And all of a sudden you've got higher water levels outside the cell than the inside. Water goes into the cell and the cell starts to swell up. We don't like that either. You know, red blood cells will explode if you put them in a dilute solution. If you were to put a red blood cell into 100% distilled water, pure water, they would not last a second. They would just explode and you'd have a red smear. If you put them into salt water that is saltier than, if you put a red cell into water that is saltier than the inside of the cell, the red cell is going to shrivel up. It's going to pump its water out. It will, we call crenate. That's what cells do. So, you know, the cells in our bodies are balanced osmotically. Salt concentration inside the cell is the same as the outside of the cell. If you mess with the water levels, then you're going to see a difference in the osmotic concentration. And that's going to cause water to either leave the cell or go into the cell. When we're dehydrated, water leaves the cell. When we are overhydrated, water goes into the cell. Neither one of those are good conditions. Anyway, normally we have about 40 liters of water in our bodies in 3 places: plasma, interstitial fluid, and inside the cells. Now the solvent is water. Solvent is always water in our bodies. The solutes are what we call either electrolytes or non-electrolytes. You know, one of you mentioned Pedialyte a little while ago about as a, you know, Pedialyte is it's sort of like Gatorade for kids, if you will.
Unnecessary.
Hmm?
Unnecessary.
I think so. Yeah. I'm not a big fan of any of these electrolyte drinks.
The liquid IV.
Yeah. Yeah. I don't think that the amount of electrolytes they add gives you a substantive effect.
My mom was drinking them liquid IV drinks and she got really sick and she called me. I told her it's because she wasn't supposed to drink them like she would regular water throughout the day.
Mm-hmm.
That she had drank too much of them.
Because I don't think you lose enough electrolytes in sporting competition. You know, like you see them drinking Gatorade, you know, during football, you know, and the Gatorade, they throw in the winning coach, whatever. You know, I don't think they add enough benefit. You know, it tastes good, you know, if you like salty orange juice, you know. I'm just not sold completely. Now, children, maybe, but you know, depends. You know, if they've been throwing up and having diarrhea at the same time, and they're losing a lot of fluid, their problem is fluid loss and electrolytes too. You know, forcing this down to them may not be the best thing. So, but I'm keeping it.
I've always done the sip on canned Coke.
Yeah, you know, so now electrolytes. What's an electrolyte? It's a salt. It's a salt that when it goes into water, will separate into its positive and negative components, like sodium chloride. Sodium ions are positive, chlorine ions are negative. Sodium chloride will dissociate into the sodiums and the chlorines. Any molecule that will separate into positive and negative components has become ionized. It's an electrolyte. Hydrochloric acid separates into the hydrogen ion and the chlorine ion. Hydrogen's positive, chlorine's negative. Sodium bicarbonate separates into the positive sodium and the negative bicarbonate. Carbonic acid gives you the positive hydrogen and the negative carbonate side there when it's dissociating. The important ones that we use in our bodies are going to be sodium, potassium, and bicarbonate, but mostly sodium and potassium. Chlorine's just watching. Chlorine doesn't get to play. It's there, but we don't use it. These are electrolytes. Acids and bases are electrolytes. Sodium hydroxide dissociates into the positive sodium, the negative hydroxide, for example. So we have anything that has a charge on it when it goes into water. The things that are not electrolytes are things that don't separate out into positively and negatively charged components, like glucose. Glucose stays as glucose when it goes into solution. Fats don't separate out into positive and negative fats. Neither does creatine and urea. Now the electrolytes, because they separate, they don't stay as one particle, but break up into two particles, have more osmotic power to draw water than the glucose or the lipids. Glucose doesn't break down into pyruvic acid, at least not on its own. Glucose stays as glucose. A glucose molecule stays as a glucose molecule in solution. But sodium chloride breaks into sodium and chlorine. Two solute particles. We don't care that one's sodium, one's chlorine. What we now see is we have two solute particles. Solute particles then determine the solute concentration. Your sodium chloride gives you two. It's more like it's going to have a greater power to move water across the membrane. The osmotic gradient is driving the water, because remember, water always goes, I can't say this enough, from high water to low water. The high water is determined by the osmotic concentration on one side of the membrane. The low water is determined by the osmotic concentration on the other side of the membrane. High water is low solute, low water is high solute. So your electrolytes are going to be a greater driver than your non-electrolytes. Osmosis, glucose still causes osmosis. It's still a solute particle. You're going to move across the membrane on which side, if you have a 10% glucose solution on one side of a membrane and a 20% on the other side, you're going to go from the higher water side, which is the 10%, and it's going to go across the membrane into the 20% side. Still, it has to do with the number of solute particles. Okay, now, well, I think I just said all this. Electrolytes dissociate into ions in water. That's the proper term. They will separate. Dissociate means they will separate into ions. These ions can carry an electrical charge because they're positive and negative. We see that all the time when we're talking about membrane potentials on muscle cells and nerve cells. Go back to AP1 and remember the whole depolarization, repolarization events. So electrolytes can conduct a current. They have greater draw for water movement across a membrane. Sodium chloride can give you two solute particles when it dissociates. Magnesium chloride can give you three. I forgot about the other chlorine there. Glucose is a non-electrolyte. It only gives you one solute particle. So the number of particles actually matters. The more solute particles you have, the higher the solute concentration. And water will always go from the higher water side, from the high water side to the low water side. High water is low solute concentration, and low water is high solute concentration. Okay, a term here, milliequivalents per liter. The number of electrical charges that we find in 1 liter of solution. A milliequivalent per liter is the concentration of the ion in milligrams per liter divided by the atomic weight of the ion times the number of electrical charges on 1 ion. Don't think it's ever going to be a question you'll get asked in any kind of clinical setting. However, 1 milliequivalent equals 1 milliosmol. Now we're getting into an area that's getting important. How many milliosmoles did I say was the standard solute concentration? 300 milliosmoles is our standard concentration. So now we know 300 milliosmoles, 300 milliequivalents. We know what the charge is. Now, is that relevant? Well, the 300 milliosmol value is pretty important to us. So within our bodies, we have cations, which are the positively charged ions, and anions, which are the negatively charged ions. We have certain ions only appear in certain places. The certain cations only appear in certain places. Outside the cell, sodium is the #1 cation. Sodium is actually the most important cation in our whole body, but sodium is the chief cation outside the cell. Chloride is the chief anion. So we have sodium and chloride dissociating outside the cell. So the #1 cation is sodium, the #1 anion is chloride. Within the cells, we don't have a whole lot of sodium and chloride, but we have potassium and phosphate. The #1 cation inside the cell is always potassium. Remember the muscle cells with sodium outside and potassium inside, and the nerve cells with sodium outside and potassium inside. Potassium is the chief cation inside the cell. Phosphate is the #1 anion. The negatively charged phosphate is inside the cell. And we see that the concentration of sodium outside the cell is the opposite of the potassium concentration inside the cell. High sodium outside, low sodium inside. High potassium inside, low potassium outside. Thanks to our sodium potassium pumps, trying to keep equilibrium for us. And there's a nice chart that shows you where everything is. Sodium is high in the plasma, in the interstitial fluid, and low in the intracellular fluid. Potassium is low in the plasma and the interstitial fluid, but high inside the cells. Chlorine is high in the plasma and the interstitial fluid and low inside the cells. We see phosphate over there, HPO4, is low everywhere except inside the cells. So the electrolytes we're paying attention to are going to be the sodiums and the potassiums. Now, movement among the compartments, and we have the plasma, we have the interstitial fluid, we have the cells. The plasma leaks out of the cells, plasma leaks out of the blood. the capillaries have holes in them. They're, and that's perfectly fine. The plasma becomes interstitial fluid. It is collected by lymphatic vessels, which is a parallel circulatory system that will bring that interstitial fluid, now called lymph, up to 2 ducts up here, up near the subclavian veins, and return that now lymph to the plasma. Of course, on the way, it runs that lymphatic fluid through all the lymph nodes to check for pathogens. And then the blood that's been, the plasma that is now interstitial fluid, which is now lymph, has been cleansed and goes back into the plasma. So it's plasma, interstitial fluid, lymph, and plasma. There's a lot of movement here, constant movement from the blood to the interstitial fluid, to the lymph, back to the blood. So, and depending on osmotic changes in the interstitial fluid or in the intracellular fluid, water will move back and forth. Generally, there is no net gain on either side. If one side gets a little saltier than the other, we send water to the saltier side to try and dilute it. So we're keeping a balance here. There's no substantive, there is no sudden surge of water from one side to the other. We're not shifting water around. We're moving water around as we need to move it around. Okay. Now, last slide here for today, and this is a very important point. You may want to circle, I even bolded it. Plasma is the link between the internal and external environments. Plasma moves quickly through our bodies. It's the only link through the external environment, plasma, interstitial fluid, and the cells. Okay, so that's a good place to stop now. So let me get us out of here. And anyone have any questions on this? Okay, then I'm gonna get us out of here. Lab this afternoon, we're gonna wrap up the digestive system today and tomorrow, and we'll be done with lab. So after today and tomorrow, no more labs, we're done. So the last 2 weeks of the semester, enjoy your afternoons. So, okay, then I'm gonna get us out of here and see you all in